Good afternoon, everybody. We are so glad that you're here to join us today. Want to first and foremost thank all of you for all the work you are doing, getting ready for students to come back into the schools. I know that your job has not eased up at all after the first 4 days or so with staff back. Know that we are here supporting you. We're all in this together. We are going to get through. We are going to do the best that we can with the best information that we have. And that's important to remember for all of you. And we at VSSNA leadership are so appreciative of all that you are doing. You've been sending lots of questions to us and we appreciate those. Please know that we are as busy as you are, and we do intend to get answers to those questions as soon as we are able to get those to you. So today we are once again welcoming our friend and colleague, Breena Holmes, the Director of Maternal Child Health at the Vermont Department of Health. Today we are going to be focusing on well, actually I'm going to let her tell you what we're focusing on, but I just want to let you know that it's okay to put questions in the chat. I'm going to ask that you please keep questions in the chat today, focused on what it is that we are talking about. And here we go. Breena, thank you for being here with us and for
Oh, you're
all the
welcome.
work that you have.
Can you all, everybody hear me okay?
Yep.
This is Breena Holmes. So I just want to echo what Soph said. I feel the chilliness in the air in the morning, which is that feeling that it's time for return to school, and this is an extraordinary year, the likes of which we have never seen and we will never see again in our lifetime. So we're all here. We have your back, and my team is at the ready if they haven't already been available to you for small, medium, and large questions. So Soph is right. This is a very specific talk today about an algorithm, clinical use only, between medical homes that serve children and school nurses. This is not a public-facing document. I just wanted to say, if there is anyone on the press that found their way to this town hall, hello, welcome. I'm happy to talk to you. Please contact the health department if you want to talk about the process and the algorithm. However, this is not going to be out on public websites. This is not for parents at this point. We are committed to taking the information about the clinical syndromes that may or may not be COVID and putting them into a one-pager that would be helpful to families to understand why things are different this year. We also know and recognize that you as school nurses are in close contact with your school administrators. I'm happy to talk this through with superintendents and principals. It has a lot of medical language in it, and I just really want to be clear that this was created for clinical decision making between school nurses and pediatric medical homes. Okay, we like the title also. Triage, evaluations, testing, and return to school. We are, as far as we know, the only state in the country that took the expertise of pediatric infectious disease epidemiologists and our school nurse colleagues to come together for this complex clinical algorithm. We certainly know other states have made buckets of who might be headed toward a test and who might not, but we spent weeks really thinking through what do we know about pediatrics and COVID and what are the pathways. So the next slide, Clayton. Clayton's in control today because I have technology issues. I started this way. I want to just add it again that I am so grateful for the role that school nurses are playing in this experience. And I also want to make sure that we recognize together that as people that seek solutions and scientists, it's very hard to have some areas that aren't fully answered. Next slide. I hope you can see these okay. And I've shared this with you before, but this is a rapidly changing situation as it relates to data, but also what we learn about the virus. So there, never before, I mean, never more in your life has version mattered. And this latest version of the algorithm we moved the date to the top, so it's more prominent. And I would caution you to always use the website when it is posted, which will probably be at the Vermont Child Health Improvement Program. I'll know more about that tomorrow, so that you're not printing out a copy and risking that we had to make some changes. Next slide. So here it is in all its glory. It's 2 pages, very specifically, because the first page, which is the next slide, thank you, Clayton. The first page is really epidemiology. This is a child who's been exposed to the virus or has had high-risk travel. It's too small to read on this slide, but I will caution you, high-risk travel gets changed frequently as well, but right now it's about that quarantine map. And the footnote there, 1, will take you to the bottom of the page where it also describes, even if you travel from a green zone, if you do that with public transportation like an airplane, that's considered high-risk travel. Back up to the top. This may be helpful for you as you interpret things with families, but I would caution you to use this page to drive folks toward the health department. So this, if you are exposed, and Clayton's going to try to navigate this, if child has known exposure and they have symptoms, that goes straight to the medical home. I really don't want you thinking you have to do anything other than that, because those kids need testing. We're spending a lot of time with our pediatric college thinking, where are you going to get kids tested? Are you testing in your office? What are the resources in your town? But that's the path toward test. If the test is negative, it's a very complex decision about return to school, because it relates to when were you exposed, is the exposure ongoing? And then that's why we opted to say, if you're in your home exposed to a person with COVID, you must call the health department anyway, because you're a close contact. And even in a negative test, there's some nuance. If you are negative and you're not having an exposure at home, the pathway back is all 3 of these conditions. You have to be fever-free, your symptoms have to be improved, and you have to be clear that you're 14 days out from the exposure, because as you know, a negative test today doesn't guarantee that you didn't contract COVID and you would be coming positive tomorrow or Saturday. If the child with symptoms goes to the medical home, gets a test, and it's positive, that's a very straightforward CDC recommendation of the 3 clinical conditions to return, either to work, this is true of adults too, or to school. You have to have had 10 days since your symptoms first appeared. You have to be fever-free for a day without any fever-reducing medication, and you have to be improving. And then there's the group of kids that had that known exposure, but they don't have symptoms. And this, again, is quite complex. So if you're still in the house and you don't have symptoms, but a person has COVID in your house, then you either have to leave the house, try to isolate away from that person, and we've had circumstances where a patient can do neither. And if you just remain in the household and your caregiver has COVID, you have to finish your 14 days from the time the person got well. So it ends up being quite long, and that's that box at the bottom. If you are not exposed at home, you follow quarantine rules, either 14 days or you get tested at day 7. And as you can see, you go back to school if you're negative. So this side is important for all of us to know as citizens of the world, but I wouldn't feel that you as school nurses needed to do a lot of the translating or interpreting, because known exposed kids are going to be called by contact tracers. And all of this is going to be outlined in about a 25-minute conversation with families of kids who have been exposed to COVID. Okay, next slide, much more in our wheelhouse. I did want to acknowledge, as we're changing slides here, that the Vermont Children's Hospital contributed greatly to this algorithm, including graphic design. And the doctors Bill Raska and Ben Lee led this work. They're part of the Children's Hospital, but we brought it forth through 2 primary care docs through the Vermont Child Health Improvement Program, Barb Kennedy and Alicia Veit, who are at Timberlane Pediatrics. And then we also had our whole epidemiology team and those great public health nurses review it many, many times. Okay, so now we're in a group of kids who have no known exposure. And this is the group that many of you have asked us about for weeks and weeks. What are we going to do with these kids? So you start with the list of symptoms that the CDC outlines. Fever, cough, shortness of breath, sore throat, runny nose, lack of smell and taste, diarrhea, fatigue, muscle aches, and headache. So just to start on the right side here, there are a few symptoms not on this extensive list. Maybe rash or ear pain. Those kids need regular school policy about return. And that's really important to me, and we've talked before as a group that my pediatric colleagues and maybe some of your colleagues, we're forgetting sometimes our regular old infectious disease principles. So just know that there will be an occasional symptom in a child that's not on the COVID list, and you think through, what would I have done pre-COVID about this kid's return? So that's the right. On the left is something on that list. And this is where Vermont has its own low prevalence decision-making tree. You will not see this tree in other states. And the reason is we have the lowest prevalence of this virus in the country. And this is entirely based on a low probability that anyone has COVID. And that's also in a footnote, which we've moved to the top of the page 1, but please know this will be thrown away and reworked if we start having increased cases. So if a child has fever and cough or runny nose, or cough without fever, or loss of taste or smell, those kids have to be tested. So that left-hand side, those symptoms, those were determined to be the absolute no-brainers from the pediatric infectious disease point of view, that you go straight to a test through your medical home. School nurses do not have to figure this out. You don't have to find a test for a kid. You're not doing any testing. This is about who's your pediatrician, and they're going to be following this algorithm as well. If that kid does not have COVID, they can come back to school when they're well. And that's regular infectious disease principles that you're already following pre-COVID. And then if that child has COVID, a whole set of things will ensue, and the return to work or school is very clear. CDC, all 3 of these things have to occur. Greater than 10 days, greater than 24 hours, and symptom improvement. Okay, now we're in the middle zone. Fever alone, or fever with one of these other symptoms, sore throat, diarrhea, muscle ache, headache, and fatigue, or a combo of sore throat, diarrhea, muscle ache, headache, fatigue, runny nose, no fever. This is a hard box, and this is where I see a role for you to say, having teamed up already with all your pediatric medical homes, to say, we got to get this kid some clinical decision making. And what we say about this is they don't have to necessarily go in the office. This is about pediatric offices saying, I'd like to talk this through with a family, or I'd like to see the kid. But I don't want you all to feel like you have to do anything other than just acknowledge that these symptoms are consistent with needing pediatric care. And that the reason I'm saying it that way is that the pediatricians are just, as you are, gearing up for volume, and they just need to figure out, are they seeing all these kids, or are they going to get their best nurse triage person in place to talk this through with the family? It's very kind of take a deep breath and let's see how sick kids are in Vermont in what we traditionally would call our season, right? October, November. If the decision is made to test a kid in that symptomatology bucket, again, positive test, straightforward. Negative test, you can come right back to school when you're well, because you've got something else. And then the third bucket is, someone pointed out they want a different word in here. So we're taking all the feedback that you're giving us, but what we meant here was any one of this list of symptoms. Someone said it's supposed to say anyone with. I get what that is, but it's any one of fever that resolves, or sore throat, or runny nose, or muscle ache, or fatigue, or diarrhea, or headache. This is the one symptom box, just one symptom. Many of you have asked what to do with a kid that you know gets headaches, or a tired kid. And this is the box I see the most clinical decision-making going on with you and your families. This is the box where you say, I'm gonna help work through some alternative diagnoses here, because I know this kid and he gets migraines when the seasons change. And this is where you can kids can return to school with symptom resolution. So what I should have said, and we've gotten feedback that the lines need to be bolder. In that middle section of fever alone or combos of symptoms, there's more disposition than positive negative. There is a path if a medical home decides it's an alternative diagnosis. And the example we give is, fever and sore throat. That kid gets seen, he has a strep culture, it's strep. That kid comes back when he's well with an alternative diagnosis of strep pharyngitis. If a medical home talks through symptomatology with a kid, says, I'm not testing this kid, it isn't an alternative diagnosis, but he gets well, we want that kid to be really well, which is the far right, that you really have to make sure in the absence of a test that you know that's not COVID. Okay, so I'm going to stop there and say 3 remarks, and then we'll move into chat. The first thing is, this is not perfect. People have already pointed out things they just wish were different. What we've decided today with the infectious disease doctors is, this is the version for now, and we want you to start meeting with your grade school liaisons and the district health offices, with your docs and your pediatric providers. I want you to get in a Zoom and at a community level and start to say, how does this feel? How does this work? And then there's 2 more things. One, some of your great leadership has drafted up some what we call disposition forms. How do you communicate between a medical home that makes a diagnosis and a school nurse so you're clear that a kid is okay to come back because he's got strep or recovered from strep? We're working to get that finalized in a way that would be statewide distribution, but we've also heard many of you already made a form or are working on a form to talk with your medical homes about individual kids. So I really want to leave that a little to you, and I want to promise you that by early next week, you'll have an example template if you haven't developed a disposition tool. And that tool to me is really important, because the communication, we can't really statewide decide that every medical home has to fax or call or hand pieces of paper. I don't know what works best in your community. I know that pediatric offices have care coordinators. I have fantasies that the care coordinator teams will make it part of their daily job to call school nurses and say, we've got 4 kids out from your school. 3 of them have strep. They're coming back tomorrow because they've had 2 doses of, I have fantasies about how this is going to really shore up medical homes and school nurses. In big communities, I've heard a lot from Chittenden County that you're not going to be able to make those kind of, hot handoffs, I guess, and that you're going to need a tool. So I think this sort of 2-pager that talks about that the kid was seen, got tested, was seen, didn't get tested, was, all the disposition could be the right way to go back and forth, but I don't want to presume that you need us as state people to determine that pathway. I think your school liaisons are the right people to do that. So, and then the third thing is to reiterate the parent piece of this, which is essential. I feel like we are in such strong partnerships with parents already in our childcare experience, where it's just hard and people who are sick have to stay home. And if I think our top priority besides the disposition form is this communication to parents about what we're doing in these clinical decision-making algorithms to say that, you know, when we have very little COVID, we're going to figure out together why else your child has a cough or a sore throat or a fever. So I think I'll stop there, Clayton, and see how you want to move forward with questions.
Thank you, Breena. I'm going to ask you some of the questions that we're seeing in the chat for you to expound upon, if that's okay. We have several that are indicating, can you please explain what is close contact? Some folks are seeing the CDC guidelines as varying from VDH guidelines. So maybe some specific clarification on that, please.
Yeah, so, and you are also great at, you know, in my experience, sometimes I answer the wrong question from chat. So I don't believe in the arena of close contact we're doing anything different than the CDC. I know for sure that we follow a very long set of questions when talking to a person with COVID about, were they symptomatic? When were they symptomatic? Where were they? With whom? How long? And so this question from Jacqueline Becker about the less than 6 feet, 15 minutes. I don't know what you're saying about remain in school. Oh, I see. So there's nothing formulaic that I'm going to say about a kid. I'm going to wait, and it's 90% of people who are close contact are called by the health department within 24 hours. So we are going to allow the incredible contact tracing process to get the information about the exposure. So I have a lot of experience with this with childcare, and the best I can tell you is that it's never as extensive as people prepare for. It's a very small set of people that are identified as close contact. And that will be true in a school setting as well, because, I mean, childcare, by definition, everyone's less than 6 feet in the littlest. And so we often say, well, the kids that were in the classroom with the teacher with COVID, yes, they count as close contact. And then just because it's good to keep reassuring, we have a lot of experience, and almost none of those kids contracted the virus, like truly almost zero.
Wow.
And it is quite heartening to think the data. We had a great study that came out of Rhode Island too. I'd be happy to share studies with you about summer camp and childcare experience with adults who bring COVID into the building and how it doesn't transmit, especially when people wear masks. I think somebody's unmuted, which is fine, but okay. So that's the exposure question. Cindy's asking for more detail. I think what I want you to know here is we have a couple of really good documents that are making their way to you about the exact algorithm of what to expect. And I don't think that you guys want to try to figure out who has been 6 feet and who's been 10 minutes and who's been 15. I would just trust the contact tracers. And then there is some nuance about full PPE that we got some clarity on today, which is that when healthcare professionals are in full PPE, they are, as long as they were masked, they are not often considered close contact when a patient they were with ends up with COVID. But again, it's too cumbersome for me to go try to do formula answers here when it's such a specific process.
Thank you,
But I
Breena. I
do recognize
appreciate
you're
that.
getting a lot of questions about this, and I know it's hard for you as the health professionals in a building to be the one that people are like, how do we get ahead of this? And the answer is you trust the health department. Really important to me. Soph, do you
Breena,
want, I can do the chat too now. Yeah, go ahead.
Okay. No, I'm fine with that. I was just going to ask you a question about, it seems to keep coming up. So are you wanting the school nurse to help decide whether or not a child needs to go home because maybe they really don't have COVID, or if they have any of the symptoms that make them ill, we send them home until we know differently?
Yeah, so you guys are great. That comes up all the time. I would say the vast majority of kids with any symptoms on this list are going home. But if you know your kids and you're in the single symptom bucket on the algorithm and Johnny has fatigue, you are skilled professionals who can say, Johnny is always tired in September because he has seasonal allergy. You know, I really want you to know that there's a subset of kids with single symptoms that you can make that decision about. But if you're not comfortable making the decision, or if it's just COVID and no one is managing it well, that's the childcare experience is everyone goes home or no one comes, which is even better. And it's not working for a lot of people. I keep getting these really interesting emails from your colleagues saying, Breena, how come you're not using common sense? And it's a pandemic. I am very grounded in common sense. I was a very solid diagnostician of knowing when a kid had a headache from stress. But if you don't know a kid and he comes in looking a little glassy-eyed and he's got a headache, you got to send him home. It's really important we start there. But I also want you to feel that you've had conversations with pediatricians through the September where you know, are you guys going to send these kids home for a day and do a 24-hour recheck? Are they going to call the doc the next morning? How does your team function? And I mean team, you're on the team with the medical home. Team-based care. I mean, this is what I've dreamed of with our kids with special health needs, and many of you have already accomplished, which is you know each other, you know the pediatric medical home, and you know what to do when a kid comes in with his, chronic cough. So the other question I saw that came up a few times, because you're all so great, what if you don't have a medical home? What if you just moved here? What if you're finding a disconnected kid? And to me, this gets us back to your essential EPSDT Medicaid fund. We want all kids in Vermont to have a doctor and a dentist and health insurance. And the data is so good on this. And as you know, depending on the year, 98% of Vermont's children have health insurance, sometimes 99%. And every pediatrician in the state of Vermont takes Medicaid. So there's no access problem here from a system perspective. So you guys have a really important job this fall, as you do every fall, which is, just because Johnny has Medicaid, he's not currently connected to a medical home. His doctor moved. He doesn't go to his doctor because he has transportation challenges, or families have high deductibles and they don't like to access health care, so we're really here to help you with all that, but you're in a perfect position to do it. So this is going to shore up our health access, because everybody needs a doctor during COVID. So I hope that helps, and you are welcome to call the health department. And we have some pathways for some free care. We also have the Federally Qualified Health Center system. But in child health, we really have our network of pediatric providers who will take any kid. And if you hear differently, I need to know, because that's one of our mission statements. Jennifer is asking about siblings of students with symptoms. This one's really important to me as well. Business as usual for the kids that are the siblings. If you hear that, Sarah's in school and her brother's home coughing, we have such low prevalence that there's no behavior change for Sarah. There's no behavior change for her parents. It's just the symptomatic person that stays home. and you know, comes into this algorithm. And we've gotten a lot of questions about teacher-child pairings, because a lot of our educators are parents. And if a teacher's sick, the kids can still go to school if they're not experiencing symptoms, and vice versa. So if you have a sick kid who can go home and get care from someone else, his parent is free and clear to continue teaching or working. Jamie, I hope I answered. Let's talk more about health access and what to do with new students. That's another topic when you sit down or Zoom down with your pediatric medical providers in your town, is to say, I've got 5 new kids and they don't have doctors. I hope you know that the pediatricians are fully engaged with this work and algorithm, and they really want to help you. And it's going to be, I think, long-term really enhance your relationships or build on ones that are already terrific. Susanna's asking, can we share this with our school pediatric HCP? Of course. I think HCP means healthcare provider. I didn't mean to skip over Alyssa. Can a nurse sit outside with a student who's going to isolation to wait? Yes. In fact, your great leader, Soph, has been promoting outside waiting all along. It is always, always going to be less transmission of this virus outdoors. Annie's asking, could we use this guidance for teachers and staff? Great question. This is nuanced to pediatric healthcare because kids experience symptoms differently. They experience COVID a little differently. We know the adults need their own algorithm, and we've asked some of our adult primary care colleagues to partner with the adult infectious disease doctors to think about adults returning to work with a little bit of urgency around the 18,000 teachers, staff that will be in our school buildings. And we have some good traction this week. There are a few primary care docs ready to look at this with us. So I'm hopeful, you know, I've stopped putting timelines on things, but the adults need this too, but it is not this same thinking, which is tricky but true. And it's the way the symptoms come forth. Okay. These are going to be the harder questions for me to do real time. Cough only, or with shortness of breath, box 1, what does symptoms improve mean for a lingering cough? Okay, that one I can do. If kids have new cough and it lingers, they're still contagious and they need to stay home or see their doctor and be diagnosed that the lingering nature of the cough is because they now have a reactive airway that's more like mild asthma. So that is not up to you to try to sort. If kids are still coughing, they need to stay home unless they've been moved into a different category clinically, which is that they actually have chronic cough. And chronic is, you know, defined as more than 10 days for some kids. So a lot of clinical decision-making around cough. Jacqueline Becker saying, middle box, if not tested, keep out per CDC. That one I'm gonna need you to email me because I don't know if you mean middle, I think you mean middle box on page 2 because that's where all the action is with the symptoms pairing up. And there's 4 dispositions for that middle box, each of which require medical decision-making. Stephanie's asking, I'm being asked if my school could think about purchasing Abbott. So another day and time, we should decide how to talk together about the growing number of testing platforms, their accuracy, their sensitivity, and Vermont's approach. We are not currently recommending the Abbott test. Other states are. I will tell you, because we're small and awesome, we had a serology work group, which was infectious disease doctors, laboratory scientists, and epidemiologists. Serology is antibody testing. That group was so committed, so successful, and so good at reviewing all the testing platforms and the literature that the health commissioner asked them this week to be his scientific advisory group. And we met yesterday, and they are still not recommending these Abbott tests. And there's a lot to say there. Leah's asking, the really well seems long, 10 days. Again, if you could explain, because I can't move very easily between your chat and the algorithm, so I'm going to come back to that. Email me. Jamie, this is not on the VDH website yet, partly because of what I said at the beginning. We're working through a journey of whether this is a public document, which would be fine. What we want to avoid is a person seeing this, having had a different disposition path from a clinician, and then we're kind of at odds with clinical decision making. So I think the place it's going to live most definitely is at the Vermont Child Health Improvement Program's website, and we may have a link to that in the health department. So I have to get back to you on that. Clayton, by showing that, I've now lost the chat.
Okay, I didn't know if it would be helpful for me to have that up or not. So I can always bring it back up if you
Well, I think, no, I think I'm going to make a general comment. I think these sort of specific, as you start to go through where you're like, wait, really well, I don't know what you mean. I think those are great for my team by email, because we want to start to see where the ongoing areas that make no sense, but I would also bring it to your clinical teams with the pediatric medical homes and see if you can define it. Because, and the only, I'm not at all, I could totally try to answer everybody's detailed questions. We just feel that the group that has met about this for 6 weeks feels like it's as good as it's going to be right now, and then the parts that don't make sense, you have to feed back to us in a more organized process, so we don't edit this every day. That's what we got into. This didn't go great in terms of version control, which I should have said to you guys at the beginning. I have learned so deeply that we are not going to have perfect answers every day the way we did pre-COVID, and the imperfection of some of the communication sharing has been really hard on me and my team. Because we wanted to get this out to people, and we kept sharing it, and then it had some areas that needed clarification. And Ashley's asking if it's been shared with pediatricians statewide. So we shared it through our Vermont Child Health Improvement Network, which is, 80 probably out of the 100 pediatrician colleagues and lots of family docs. But we're also going to share it through Family Medicine, Vermont Medical Society. But we do have people that do their own thing. Dartmouth has a little bit of a different algorithm. It's not terribly different, but Mandy's asking about the border towns. That's tricky. I mean, anyone can share it. If you have catchment areas in New York, you're welcome to say, hey, here's Vermont's document. What do you guys think? It's just not clear to me whether folks want to use it. Jenny's asking my favorite quarantine question. If you go somewhere and it's green and then people come in yellow, do they have to quarantine? So this is not officially written anywhere that you as a green zone have to know people's zone status. But what Dr. Levine says about this is about your own stewardship and your own ethics around COVID. So if you know you've been around people from a zone that's not supposed to be somewhere, yeah, you should quarantine. And you need to ask yourself, what was your exposure? How long? Were you outdoors or indoors? Was everyone masked? Were you less than 6 feet? How long? So that's a really nuanced, good question, but it's important. Susie's asking, what algorithm are we meant to use when trying to help faculty or staff? I think I answered that. Yeah, that's forthcoming, hopefully, and adult primary care. Tara's asking, no test, no alternative diagnosis will be very difficult to enforce, particularly when students do not get in touch with a medical home. Yeah, I agree. But remember, the no test, no alternative diagnosis is one of the 4 dispositions in the group that we encourage medical home contact. So you, as the keepers of that, of school nurses land, can really encourage and partner that, you know, and make sure that occurs. Cindy's asking a good question. Who has the final say, the school or the Department of Health? Okay, so everything about this is guidance. There's no, you know, we've done a really good job in Vermont not attaching any kind of stigma or punitive action for people's movements and decisions. But if a kid, I guess what you're asking is, if a kid comes back to school that's still not well and he hasn't had the clinical decision making, he needs to go home. That's one of the absolutes of our guidance. So if, Cindy, if you have more nuance there, type it back in. But sick, no one sick should be in the building. And if a kid comes back with some symptoms, but he has X, Y, or Z determined as alternative diagnosis, then he is welcome. Claire saying, my principal says those kids will be offered full-time remote until the MD contact. So, right, that's super interesting. So that's its own interpretation that but remember, if you're not well, you should be allowed to heal and get well and not be taking remote class. You know, I think that comes up with adults too. Are you going to still be teaching or working if you're ill, or are you supposed to be getting well? Lori is asking, page 2, do we exclude kids who fall in the middle block for whom we're encouraging a call to medical home to determine the need for cover test? Yes. So because they're sick, they have symptoms, and they need to talk to their medical home. Okay, Leah's asking, for those of us who have delegates, they cannot make the assessment, they'll just have to be sent home. That is true. And Elizabeth's asking, what about staff? Yeah, you guys are right with me on this. I've been working on the adult side for a while, but it's not breaking open the way I guess I'm going to be strength-based and say the pediatric medical community and the public health people who work with children have been integrated for 30, 40 years, and the integration has really allowed for this type of document production, and we don't have that same integration to get things like this going in the adult world, but we're still trying. Ashley saying, anyone with symptoms goes home, but can you provide guidance on what you would consider suspected of having COVID? Okay, so Ashley, thanks for this. We got into a pickle with the word suspected. So one of the documents that we were really excited about that our outbreak prevention and our epi teams made was, hey, schools, here's what you can expect if you have a case in your school. But they used the term suspected COVID, which led to many, many of you, and I'm so grateful, pointing out that word is problematic because on the most literal interpretation, it could be anyone that with a symptom associated with COVID, but suspected really in this document that we're talking about that I can send, well, I'm not going to send you because we pulled it back. What we really meant was you've got COVID in the building and now you have to do a whole bunch of things. So stop right there and know that we're going to fix that word, because that guidance was supposed to be about a classroom with a known case, or, you know, and it's really botched. So if people don't know what I'm talking about, you can just ignore what I just said, because it means you haven't seen a document that's being fixed. Betty's asking, what do we do for families who haven't returned their annual health forms? So 8 times 8 ways. I think that since that's been your work for so long, so many of you, I think you know this year it's going to be paramount to get those forms. And if you can't get them, I hope you have care coordinators in your pediatric offices you can call and say, can you help me? And I think permission to partner up with your medical home is going to be even more important. And I'm just checking with Soph if it's still okay how this is rolling, because I see that we may be in endless list here, and I don't know, is this the best way to do this?
Breena, I think this is fine. I just want to remind all of you school nurses, any question that is not answered that is in the chat, as well as all the questions that we continue to ask you to send to us at COVID-19@vssna.org. We will be passing those on. We will be getting those answers, and we'll be posting them to the website and letting you know when we have that information. As you can see, we have continual questions, and each of us might be asking the same thing, but in a little bit different way, which is okay. So we do want to get as many, we will get answers to you. So Breena, I think you're fine to go the way you're going, and we have just under 10 minutes left.
Right. So if a staff member has a family member with COVID symptoms, should they stay home? I hope I answered that no. Low pretest probability, less than 1% of our tests are coming back positive. And that doesn't mean, by the way, that 1% of people have COVID, with symptoms. We're testing people that are close contacts with people with COVID and symptomatic people. So the actual prevalence is way, way below 1%. So family members with COVID, with symptoms, stay home. Everybody else, business as usual. Kara's asking about concerns not always having the release of information permission. I agree. I know most of you know I have a deep background in school health and worked in a public school, and know that I think this year I just would try everything I could to get permission signed that you're part of the pediatric medical home. I guess whatever we can do from Sharon Lee Treffery's perspective, that's a real public health topic, and we have a lot of tips and ideas for you. Allison's asking about multiple kids in the same car. Yeah, we heard about this. So if multiple kids are in the same car and one gets out of the car and has, I think what you're asking is assessed to have a fever during the health screen, or somehow got in the car symptomatic, all those other kids don't have to go home, because the kid's symptomatic but not likely with COVID, but that shouldn't have happened. So there needs to be some quality improvement on why a symptomatic person was even coming to school. So if that's not what your question was, people slip through, but we need to keep telling our families over and over and over again, do not leave that house with symptoms. And also, if you get in the car and someone's coughing, you got to say, hey buddy, you're coughing. There's this is a real time of good, solid, trusted clarity with our friends. And again, and then ultimately, if that kid ended up with COVID, the exposure to the other kids would be, if it was, less than 6 feet, less than 15 minutes. I'm sorry, more than 15 minutes. So if it's a 2-second ride, they probably wouldn't be close contact. Carol's asking, will most practices take international students even with differences in health insurance plans? Yeah. I mean, I'm super hopeful that never comes up, but please let me know if it does. I'm very fond of my pediatric colleagues. Elizabeth's asking, from a music teacher, I understand it makes sense to avoid having chorus. I'm wondering if it means no singing at all, even one person. Can I sing with kids with my mask on? So we actually did some literature review with our infectious disease colleagues to get back to the Music Teacher Association through the Agency of Ed, and we really don't feel good about singing indoors. So that's a suboptimal answer for someone that loves the joy that comes, but I would like that person to step outside and sing to her heart's content outdoors. Because if we start parsing and saying, well, you can sing, but you got to be way in the front and 6 feet away and got your mask on, that is safe. It's just that what's the enforce, we've said no singing indoors, and I have to stick with it. Lori's asking, how do we distinguish between an asthmatic cough and a cover cough? Don't know what a cover cough is, so that I need help. And Susanna's asking, please clarify again, page 2, right-hand box, any one of, yeah. That's the box that.
Breena, I think sometimes people are having difficulty. They're reading it as anyone. What you have
Right.
shared
It's
is
any one of these
one
symptoms,
of
and it should
the
have,
following
yes.
symptoms.
And it should have said with or something. Many people have said that. So I promise in a future iteration, it will read better. Flood School is asking, I apologize if this question doesn't relate to the algorithm. I just learned the school can tell families with high-risk medical compromised kids to do remote learning. Can we ask a parent for a clearance letter from a provider? Okay, there's a whole body. That question, Flood School, you should write to our team, because we have advocates, but we also have children with special health needs leaders in our department, and they're working with pediatricians, and I don't know the answer, so I don't want to say the wrong thing. But there is almost no kid who's too sick to be face-to-face, and that is really important to us. We got really preoccupied with the list of chronic conditions, but kids in Vermont have such good health care that they're in stable, even when they have chronic condition, they're stable, and they have great pediatric nurses, school nurses like you all, and they really, there's very few circumstances where a medical person is going to say that they need to be remote. So I just don't want to answer that wrong. Soph is helping with the grammar again, any one of these symptoms. I'm so sorry. So Jacqueline's clarifying, if kids get sent home with greater than one symptom and parents don't take them to the PCP, do we tell them we need to treat them as positive and keep them out? Okay, this is going to sound like a hedge, but I would encourage the team-based care. I would say, I want to talk to your pediatrician about this. We want to get Johnny back to school. It's very unlikely he has COVID. If he could be assessed, we could get an alternative diagnosis and he could return on Monday. But if he doesn't, we're going to have to keep him out. I don't want to be this dogmatic and punitive. I want to say this is a very unusual time, and we need some teams to think about what could be going on to explain these symptoms. And I know this sounds like Pollyanna, but our pediatric colleagues are ready. They know they're going to be busy. I think Claire is answering someone else's question. Kara, would this fall under public good? Like we can talk to MDs about immunization. Interesting. I'm going to let the communication rules between you and medical homes be Sharon Lee's lane. It is very clear to me from our experience that school nurses are part of the medical team, and I think what you've helped me understand is that means you can hear from the medical home, but the medical home, you can't tell them things unless you have the permission signed. So that will need some clarity, but I do think families, our childcare experience has been that families are telling everyone and calling their doc and wanting to talk this through. I don't think it's going to be a lot of people not wanting those connections, but, and I'm super hopeful. Lori's asking, I very much appreciate the work that has gone into this document and access. Oh, thank you. Please repeat the website where we can find. Okay, so it's not up anywhere yet, but Lori put that in. It's the Vermont Child Health Improvement Program at the University of Vermont Department of Pediatrics. If you Google VCHIP, I think the first thing that comes up is this thing from in the 80s or 90s used to put on a TV to stop kids from accessing some program. So it looks like Soph has answered the next question. Luke is thanking about the Abbott. Yeah, we're really lucky in Vermont, and I'll just say this because you guys are in the real nexus of this. Opening schools is not political in Vermont. it is not. It is about public health. We have the safest data and community experience from the beginning. Absolutely. And having these scientific advisors helping us with decisions about what testing platforms takes out all the politics. There's such good themes here. So can a child come home to school if a sibling is sick, or come to school? Yes. So again, siblings are their own experience. Clayton's making fun of me for only saying Johnny. I said Sarah too. I always say Johnny, but I should do gender with my examples. Kelly is asking, can you please address the case action checklist released this week that would have us empty classrooms for undiagnosed student with positive? So Kelly, that's the suspected COVID language that we've pulled back and needs fixing with apology. That case action checklist was supposed to be helpful and it's created chaos. I'm so sorry. Catherine's
Breena?
asking if a child is tested. Yeah.
I'm
Oh, it's
sorry.
4 o'clock.
I hate to interrupt.
I'm so sorry.
It's
Yeah.
4 o'clock, and we are happy to have you continue answering questions, but I just don't know if you have that time.
Yeah, I'm a little tight on time, but I feel like I think we should probably capture this and maybe do this next week too, or well, you guys decide what's helpful, because at least to my reading, there's 46 more questions. So I don't feel like even if I gave you 10 more minutes, we would get to the end.
So Dr. Holmes,
yeah.
And I think what we'll do is we're going to capture the rest of the questions in the chat, all the ones that were emailed to us over the course of the last week, and we have some other ones that still need. Share that with the group like we have been, get those responses, maybe get some themes, and if you're willing next week to do it, and we might need to move it back another half an hour because people are in school. We want to make sure it's accessible to everybody. We'll have to figure that part out, whether you can or not. That might be really helpful. If I can ask a question about VCHIP, because you mentioned that. So I put the link to the VCHIP page in the chat box. And I happened to, in my off time, read some of the fact sheets. And there was a question and answer about face shields. And I don't want to put you on the spot, but I was wondering if there's information in these facts that are pertinent to other folks. Can we capture it since it's you speaking the question?
100%.
Okay.
100%. And, you know, I did want you all to know that that resource, so I wish you could, well, you'll be so busy in schools, but Monday, Wednesday, Friday from 12:15 to supposed to be 12:45, we have committed since March 17th to meeting with all the pediatric providers, including family medicine in the state. And it's usually about 100 people. We wanted to open that up to all. I think some school nurses have found their way there, which is great. I just don't want you to feel like you have so many fora and places where you're learning. So, but if you want to join that Monday, Wednesday, Friday, while you're eating your sandwich, it is an interesting place to hear kind of the healthcare side, because that's where we're airing out, like, who's got the test supplies? Are you going to test kids? Do you want to send them to the hospital? And Clayton's right, the website has archived every single slide deck and presentation since March 17th. I've lost track, and it has a lot of great resources. It's a bit overwhelming.
But it was interesting.
Feel free to join, but also know that it's archived.
Yeah, so what I found is I opened up the fact sheets and you can keyword search. And so when face shields came up, I was interested in the response that you had. So we'll share it. We'll make sure everybody gets it. I'm not going to read it right now, but there is I think an answer that will help a lot of people with that question. Or anyway, I'm going to keep everybody on the edge of their seat for that. The second question I had before we end is, I've recorded this session, but because of the information in this session, do you not want me to post on the website and then just send the recording to known school nurses? Or
no, I'm fine. I'm absolutely fine. I think everyone needs to know what I just don't, there's clinical language in here that not every doctor in Vermont has agreed to, I guess. So what I'm interested in, and you guys know this experience, if a child goes through a different pathway and a doctor says, I'm not testing you, or you can just go back to, you know, there's clinical decision making that's not in this algorithm. And I don't think it's good for Vermont if we're telling, you know, every doctor they have to do everything exactly like that. I don't know. It just makes me feel like it's a better space to see it as a collaborative document that's going to be tweaked and worked through in your communities. So as long as people, I think I did want to end with those remarks because you're all so steeped in this. We can't adequately create guardrails on every question. And as scientists and clinical people, we seek answers, right? You and me, because we went to anatomy, physiology, where we actually know where the artery is. We know where which antibiotic works. It's a fascinating time for clinical people like us to have to say, I actually don't know, or I think it's probably okay, let's try it. And the example I'll give is the face shields. We do not want children wearing face shields. But if they're in speech and language for a 25-minute session and no one can figure out an alternative mask that could show them out that would teach a kid what he needs to learn during his speech and language work, he might need 20 minutes with a face shield, see? It's nowhere written. I don't want to add that level of nuance when we're talking about case by case. Let's figure out what works and what doesn't and keep asking each other shared experience. So I did want to end there by saying this algorithm gets us as far as we can get for today, but it's got imperfection already, and I look forward to hearing what your communities like and don't like about it. So I think I'll stop there and look forward to the next question.
Breena,
the next session when I'll answer more questions. Yeah.
We are so grateful that you are here and the amount of time and energy that you put into supporting us, answering our questions, reinforcing our concerns, and just, I have to tell you, I love being able to say, well, you know, I could ask that question of Dr. Holmes and I'll get back to you within the next couple of days with folks. And I'm so blessed to be able to talk to potential hires for school nursing and say, we are the best and we have the best support. And this is the greatest place to work. And yeah, maybe going to work in COVID times is not ideal for most places, but here in Vermont, we are supported as school nurses by our medical community, by our state level Vermont Department of Health. And it's wonderful to know that. These questions that everybody asks are so pertinent. If you haven't asked it, we probably have. We are going to continue to work with Breena. Ideally, we'll bring her back next week, but we do have to double check her schedule, probably triple check it, because sometimes we have to keep sometimes we haven't checked all of our calendars before we agree on something.
Yeah.
So again, you're still on vacation today. So thank you so much for agreeing to see us and answer questions and work with us. And those of you, school nurses, we'll get the questions to you, the answers, I'm sorry, we'll get the answers to you as soon as we possibly can. And we should be able to let you know early next week whether we will be doing a session with Breena next Thursday, which would probably be 3:30. So again, thank you all very much. And we look forward to chatting with you all next week. Thanks again, Breena.